Hi, good evening, everyone. I am Shunsuke Fukuba, a clinical fellow of the Department of Periodontology, Tokyo Medical and Dental University. It's my pleasure to join the fourth Osteology Case Competition. I would like to talk about today is periodontal regeneration with a focus on surgical intrusion technique for the hopeless tooth with severe endoperiodontal region. Let me introduce my patient, who is a 50 years old female with a chief complaint. My teeth are moving and sometimes they are swelling and hurt. There are no health concerns and she's a non-smoker. From the periodontal tissue examination, I noticed numerous sites of deep probing pocket depths greater than 4 millimeters throughout the mouth. According to the classification of the periodontal disease, I diagnosed this patient with generalized periodontitis, stage 4 and grade C. For this presentation, I would like to focus on rotated number 22. The pulp was non-vital by the electrical pulp test and cold pulp test. According to the classification of endodontic disease and endoperiodontal region, I diagnosed this tooth with pulp necrosis, symptomatic apical periodontitis, and endoperiodontal region without root damage in periodontitis patient, grade 3. There was no dental history of trauma and cavities. I consider the pulpous necrosis by the ascending pulpetus. It means primary periodontal region. The prognosis of this tooth was hopeless, but we should keep in mind that the prognosis can be changed dynamically after the treatment. I performed the initial treatment for the tooth number 22, as well as whole mouth, included with root canal treatment and scaling and root planing. This was the result after the initial treatment. The soft tissue was extremely shrunken and the improvement of the periodontal tissue was obtained. The attachment of the distobuccal aspects of the root still remained. Dental X-ray images show severe bone loss around the root. From the CVCT images, bone loss extended beyond the apex, and also the apex exists outside the alveolar ridge. Gingival recession with her high smile line raised the aesthetic problem. She denied the tooth extraction and wanted to save her tooth at any cost. In this case, the conventional periodontal regenerative treatment is beyond the indication, and the result is also unpredictable. On the other hand, implant placement requires enormous hard and soft tissue augmentation, and the periodontitis susceptible patient has a high risk of the periimplantitis. The prosthetic replacement requires the preparation of the intact proximal teeth. I used the following questions to determine the treatment plan. Is there a functional value of the preserved tooth? Is there a patient desire and an adequate informed consent? When is the life stage of the patient? Is there a subsequent alternative treatment plan after the tooth is lost in the future? From the recent paper, Dr. Cordrini reported the periodontal regeneration for the hopeless tooth severely compromised by the attachment loss to the apex, revealed amazing clinical outcomes in a long time period. Also, it was cost-effective compared to the dental implants or prosthetic replacement. The other paper looked at the timing of the implant placement for the periodontitis susceptible patients. The authors concluded that the latter, the better. One of my mentors, Dr. Saida, and I reported the efficacy of flapless intentional replantation with enamel matrix derivative for the hopeless teeth. This is one of the cases in this paper. The tooth number 33 was compromised with severe endoperiodontal region after the initial treatment. Complete debridement of all root surfaces may be not achieved by the conventional periodontal regional treatment. Then the flapless intentional replantation was performed on the tooth. In summary, gentle extraction, complete debridement, apicoectomy, enamel matrix derivative application was performed. Then the tooth was replaced and fixed with the proximal teeth. 2 years after the surgery, the periodontal tissue was improved and stable. In this paper, flapless intentional replantation was performed in total 70 cases, and success rate and survival rate was over 80% and 90% respectively. This is another case in the paper. About 3 years after the replantation, the tooth number 27 was finally lost by the vertical root fracture. From the histological image of the distal aspects of the root, no ankylosis and no root resorption were observed, and interestingly, new cementum was formed. Based on these reports, I plan to save this tooth by the surgical intrusion technique, which was slightly modified intentional replantation. This procedure aims to achieve the complete debridement through the replantation. Reducing the risk of ankylosis, enhancing the new cementum formation, EMD is applied. To improve the crown root ratio and alter the tooth position, the tooth is surgically intruded at the deeper position within the created socket. Periodontal regeneration using with autogenous bone and DBBM and collagen membrane in layers is performed. Coronary advanced flap aims to augment the soft tissue also. In this case, the tooth was gently extracted, and the socket for the intrusion was created by the trim bars, and autogenous bone was harvested from there. The tooth replica, manufactured by 3D printer, tried to check the depth and direction of the socket. The vertical incision was performed for the coronary advanced flap intended to the tensionless suture. You can see the extracted tooth was accumulated by the plaque and calculus. After the complete debridement, using the ultrasonic scaler under the microscope, apicoectomy was and the retrograde filling of the root canal was performed. Through all the procedures, the root surface was keeping wet with normal saline. After the root conditioning with EDTA, EMD was applied to the root surface. The tooth was replaced at the apicary position and fixed with a proximal teeth. Autogenous bone, DBBM, and collagen membrane was placed in layers. Finally, extended flap was sutured with coronary advanced flap. You can see the radiographically bone fill around the root just after the surgery. Primary closure was kept 1 week, 2 weeks, and 1 month after the surgery. 6 months after the surgery, periodontal tissue was improved and stable. Removing the resin cement fixed with the proximal teeth, 1 degree of the tooth mobility was observed. It may be indicated the intruded tooth was not ankylosis. At 1 year, we can see the radiographic bone fill and increased density of the lamina dura. The periodontal tissue was also stable, and the patient maintained excellent plaque control throughout the treatment. I need to closely monitor the tooth through the continuous periodontal supportive therapy in the future. When compare pre-op and post-op images, you can see the improvement of the aesthetic, and the patient was also very satisfied with the outcome. From the CBCT images, radiographic bone fill indicated the prognosis of the tooth was significantly improved after the treatment. Here's my summary of this case. Under the proper examination and diagnosis, when the tooth has an accessibility to perform complete debridement, and also the pulp is vital, conventional periodontal regeneration treatment is the first choice. When a hopeless tooth with severe endoperiodontal region is impossible to achieve complete debridement by the extended flap, non-vital, and single-rooted, replantation will be the final treatment choice to save a tooth. Surgical intrusion technique has the potential to dramatically change the prognosis of the tooth through complete debridement improvement of the crown root ratio, and alteration of the tooth position. Therefore, we should always consider carefully and try to save the precious dentition. Thank you for your attention, and I hope you enjoyed this case presentation.
Thank you so much, Dr. Fukuba. I think many of us are breathless and partially speechless after seeing the quality of your care that you provided to this patient. I think this serves as a testimony of what excellent combination of excellent surgical technique, the thought process behind it, and a collaborative patient can achieve in the maintenance of teeth. Thank you also for walking us through the thought process. It was very clear on how you approach the case and the rationale for each one of the steps that you took, particularly taking care of the lateral incisor. So I would like to start by focusing on technical aspects of what you showed us in your case, not necessarily focus only on that tooth, but you also used splinting to treat some other teeth that were periodontally involved. So my question to you, I noticed that you use a gray material. Is the first time I see that, and I am curious about what type of material do you use, and also what is your protocol in terms of how long do you keep a tooth splinted after doing either surgical or non-surgical therapy?
Thank you for your question, Dr. Avila. And the protocol of this technique is no, sorry. Maybe your question is about materials. Is it?
Yeah, it's both. I was curious about that specific material because I personally haven't seen that before. And also, how long do you usually keep it, whether you do non-surgical or surgical therapy?
I usually fix with the projection teeth after the surgery about 6 months after the surgery. And after the re-evaluation of the periodontal regeneration, if the mobility was still remain over the 2 degree of the tooth mobility, I need to keep the fixation of the tooth in usual. And in the non-surgical therapy, if the tooth has an how to say, if it depends on the degree of the mobility of the tooth. If the tooth have under the 1 degree of the mobility, I usually perform the occlusal adjustment only. And if the tooth has over the 2 degree of the mobility, I use the connect to the fix with the projection teeth.
Thank you. And what about the material that you use?
In this case, I use the original bone and deproteinized bovine bone mineral. And
I mean, the splinting, sorry for interrupting you. I was talking about this, yes.
I use the resin cement. It means the super bond in the commercial name, yeah.
Thank you.
Yeah.
So you were talking about the regenerative materials that you used, and actually I was going in that direction now, so it was a great segue. What is your rationale for applying multi-layer type of material? First, I believe that you use autogenous. Where do you harvest the autogenous bone from? And then you applied a layer of exogenous material. I believe it was an allograft, right? And then over that, I believe that you didn't apply a barrier. So I would like to hear more about why you took that approach.
The original bone is harvested from the socket, and the original alveolar ridge bone, because I need to create a socket from there. So, I place the materials in layers because the original bone is the gold standard, because it has osteogenesis and osteoinjection and osteoconduction also. So I placed the most closely area of the root surface of the tooth. And I used the DBBM. It's is known as very slow resorption rate materials. So I want to keep the regeneration volume and space for the regeneration. I covered over the autogenous bone. And I refer the Dr. Daniel Booza's technique for the GBR. He used the layering technique, similar to this technique. So I refer to use this technique, in the place the material in layers. The collagen membrane is aimed to aim the bone graft material to improve the stability of the bone graft material, and also the blood supply. Yeah.
Thank you. So my last question before I turn it over to the other members of the panel, I would like to now move to the soft tissue component. So there are some people that argue that when you were treating these type of sites where we have an abundance of granulomatous tissue, we have to be very thoughtful about how much we remove and where we remove it, thinking that preserving some of that tissue being inflamed and diseased, after removing the primary etiology and through the process of healing, we can maximize the preservation of that soft tissue envelope. So I wanted to ask you, what is usually your approach in this type of heavily involved periodontal teeth when you're debriding? Do you proceed with a very aggressive debridement and anything that doesn't look healthy you remove, or do you have some consideration to preserve part of this tissue?
Thank you for your question. And the tooth compromised with the severe bone loss, it's difficult to debride completely, and in non-surgical therapy and surgical therapy also. And I use the usually ultrasonic scaler and hand scaler under the localized anesthesia. I try to remove the calculus very softly and carefully, but in this case, the thickness of the soft tissue was very, very thin. So after the initial treatment, the soft tissue and is very shrunken.
Right, thank you. I would like to then turn it over to Dr. Toma and Dr. Rios if they have any additional questions.
Yes, I do have a question. Well, congratulations again. I think it's beautiful to see what you can do with a lot of skills, and you basically used all the surgical techniques, all the materials that you could ever use to save a tooth. Just, continuing or think about the process, if you really do all the treatment, I think one of the disadvantages is that, or maybe the other way around, I was wondering whether you would later consider doing an extrusion of the tooth. The problem is that your bone level and all the soft tissues are relatively high apical. So it would actually be more ideal to do very slow extrusion, in order to have the bone and all the soft tissues more coronally. Is that something that would be possible? Have you ever done something like that?
Thank you for your question. And it's very difficult question for me. And I never do place the tooth more deeply positioned. And after that, I extrude it after the surgery. But I think biologically, if the attachment between the root and the bone we get. Maybe after the intrusion of this tooth more deeply positioned, and extrusion maybe can be soft tissue, and bone will be more, how to say, more coronary position. We can achieve that.
Thank you. I think theoretically, because you don't have an ankylosis, I guess when you see a tooth being mobile, theoretically it would be possible. Maybe another question. In the beginning, you were talking a bit about alternative treatments, and you certainly correctly explained that maybe implants are far from ideal in this case. Apart from the risk of having a higher risk for peri-implant disease, is certainly also that there is just nothing left. There is no bone, no soft tissue, nothing. I'm just wondering whether you ever thought about alternative approaches like having maybe a resin bonded bridge.
Thank you for your question. And when the first visit of this patient, I suggest her the several treatment plan. And one is to extract all the hopeless teeth and implant placement with hard and soft tissue augmentation. And ideally, maybe orthodontic treatment is needed. And the other plan is, as you say, the proximal prosthetic replacement, and not like a partially fixed denture, not full coverage. And but she denied this. She didn't accept this treatment plan. So I try to save this tooth.
Okay.
But
and then maybe just one question. It's about case selection, I guess. I mean, it's a huge sequence. You need the compliance of the patients. When do you see really a specific indication to perform all this treatment? Is this only a small or a minority of patients, or what kind of patients, what do they need to fulfill that you would do such a treatment?
Thank you for your question. This technique is still developing, and I need to evaluate the further evaluations needed. And the indication of this technique is not so wide in actually. And for example, the main target of this technique is for the tooth compromised with the severe bone loss due to the endoperiodontal region, and especially primary perio. It means the severe bone loss around the root, beyond the root, and the other factor is the age. The younger is better, and the single rooted is better, and so.
Okay, so you're still evaluating where there are really good indications, but we had seen also in the publication you showed that it's even possible with molars. Thanks again. So I would like to hand over to Hector. I see we're running a bit out of time, but you might have a last question.
Thank you, Dr. Fukuba. Congratulations again. It's a great case to also see what's ahead of us. And there are a lot of aspects that obviously are still developing, but nonetheless, it just really reflects great quality, great work, and congratulations to you. I want to ask a question from the audience that was posted just a few minutes ago on regards to the material that was used to create the replica. Basically, what type of resin, was used?
The replica was manufactured by the 3D printer and based on the CBCT images, and that is made by the like I don't know in the detail, but like a plastic material.
So it's a resin. Yeah. Now, I have a question on regards to the histology. Interestingly, you were mentioning new cementum formation. And with this approach, what's the estimate of new attachment and new cementum formation that you've been able to document with the histological analysis?
I consider that the new cementum was achieved by the remained periodontal ligament cell of the root, and usually the endoperiodontal region, the tooth has the endoperiodontal region. Some area of the attachment was remained, and so it means that maybe periodontal ligament cells still arrive at the area. And replantation, it has a very big benefit to check the root surfaces outside the mouth, and we can distinguish the vertical root fracture or cemental tears, and also perform the complete debridement. And we can see some area is periodontal ligament cell is alive. So if and when I apply the EMD, and I aim to promote the periodontal ligament cells of differentiation and more active. It maybe that's why the.
Thank you.
Please finish. Yeah, I didn't mean to interrupt you. I thought you were finished, Dr. Fukuba.
Maybe that's why the new cementum was formation was achieved.
Yeah, I was gonna mention that this is a very interesting conversation, because I think you could also challenge whether there was any viability of the periodontal ligament in that area. Just looking at the clinical presentation and the tomographic images that you presented, but there's obviously an integration of the tooth, if you want to call it that way, right? So, and appears to be mobility. So there has to be some sort of interface between the tooth and the underlying bone. And that opens up the question of whether you need really periodontal ligament cells or mesenchymal cells, potential mesenchymal cells from the periodontal ligament. There's evidence, and actually a very interesting paper just came out in the Journal of Dental Research, that there are niches of mesenchymal stem cells in other areas. We knew about endosteal areas within the bone, which is probably where most of those cells that worked to the benefit of this patient were, but there's also niches within the gingiva. So I think that this is also a very interesting question that obviously would have to be answered with an animal model, maybe by labeling some of these cells and seeing what the fate of these elements are. But maybe we don't need to have a very viable or an intact periodontal ligament to achieve successful regeneration, as we used to think back in the day. Well, I don't know if any of the other members of the panel have further questions or remarks before we close the session for today. I believe that just looking at their faces, we're good to go. I would like to thank you all. First, all the attendants. It has been a wonderful session. I hope that you enjoyed it. I would like to also thank my fellow members of the panel, but above everything else, our two presenters, Dr. Myra and Ahmed, and Dr. Shunsuke Fukuba. It has been an excellent session. Thank you for your time. Thank you for sharing your knowledge. And I hope that everybody has a great rest of the day. Stay safe and stay healthy. Thank you very much.
Thank you.
Thank you very much.